Our next talk is by Dr. Dipti, madam. My patient is still moving the legs, failed spinal. What do I do now?
Thank you, Chetna and Urmi, for doing a tough job of finishing the lectures in a time. So my topic is patient is still moving the legs after the spinal anesthesia. What do I do now? So this is nothing but the failed spinal, and I am sure all of us would have come across this and would have dealt with this. If we see the history, in 1898, August Bayer and his assistant Hildebrand, they injected cocaine in each other's subarachnoid space. Hildebrand had no pain to cigar burns and a hammer blow, but for Bayer, there was no loss of sensation. This was equipment or an operative failure. Leakage of cocaine solution while injecting into subarachnoid space led to a failure, and this was omitted from the report, and this was probably the first failed spinal. No. And if we let us see few clinical case scenario which we routinely come across. This is a 70-year-old man coming for TURP, having severe COPD. Medical treatment is given and he's been stabilized. Now spinal is given but it has failed. Next is ortho guy who is 90-year-old coming for a fracture trochanter. He had to be fixed on a fracture table and spinal is not working. This is emergency cesarean section. She's coming for fetal distress and she just had a meal and came for the surgery. Again, spinal not working. This is young patient with a mid-ureteric stone and having landed up having failed spinal. So what is to be done? We know all that spinal anesthesia is most reliable type of a regional anesthesia block. So failures are unacceptable. Now failures and inadequate blocks are two different entities. Failure means no effect at all. An inadequate block can be in the form of extent, duration, and the quality of the block. Gaston LABAT, actually he said in 1922, he is considered as a father of a modern regional anesthesia. He said that two things are absolutely necessary for spinal to work. One is puncture of a dura mater and injection into subarachnoid space. And I think this holds true till now also. Incidence ranges between 1 to 17% with the most experienced person to a teaching hospital. So we should pay careful attention to bring it down to 1% to get the benefit of a spinal anesthesia. We all know the steps of spinal anesthesia, that is lumbar puncture, CSF comes out, drug is injected, drug spreads and it blocks the nerve roots and all. But lacunae at any stage can lead to a failure in the spinal and spinal goes to ASHTRAY. Let's see the mechanism, but why we should understand the mechanism of a failure so that we can avoid it, and technique is to be performed in such a way to minimize the risk of a failure. The causes broadly can be divided as technique related, drug related and a patient related. Successful lumbar puncture is equal to 100% effect is a myth actually. Dry tap can happen because if the needle is blocked, patient is obese, anxious patient, incorrect positioning and all. But let's say if the commonest cause is the misplaced drug. Anterior or a posterior displacement of the needle can happen when you are injecting the drug or while you are aspirating. So always carefully connect the needle, carefully connect the syringe to the needle, hold the needle with the thumb and the finger and support your dorsum of the hand to the patient's back. So there is less movement. Now they suggest that aspirate halfway or in the end. Neither of the practice has improved the failure rates. Misplaced drug can occur with any type of needle, but it is more seen with the pencil point needle because the opening is proximal and it's very longer opening. Now dura can be straddled at the needle edges. So half the drug only goes out inside the subarachnoid space and half goes outside leading to a failure. Dura can act as a flap valve. So when you have punctured, because of the CSF pressure, dura is pushed outside and the aspiration is positive. But when you are injecting, dura will act as a flap valve and drug goes to either to the epidural space or a subdural space. Now this subdural space is a potential cavity between the dura and the arachnoid, and this contains small amount of a serous fluid. This extends from lower border of the S2 to the cranial cavity. There is no communication with the subarachnoid space. And this continues on the cranial as well as the spinal nerves also. This space is not intentionally used by the anesthetist, but injection into this can occur during the spinal anesthesia. So this explains sometimes the failed spinal and the total spinal after epidural, which is not very common. This is widest in lateral and the posterior aspects, so blocks the posterior sensory fiber and sparing the motor fibers. Incidence with epidural is low, it is around 0.8%, but with myelography they suggest it is around 1 to 13%. And with spinal, true incidence is very difficult to know because CT imaging is not possible for each and every case. So it is difficult to prove or disprove that injection has occurred into a subdural space. Clinical symptoms are the extensive block, relative lack of sympathetic block, incoordination, no apnea or a progressive respiratory depression. Now it has been suggested that DURA-straddling, DURA-FLAP valve or injection into subdural space, if we rotate the needle at 360 degree before the aspiration, we can minimize the possibility, and rotation reduces the risk of membrane edges catching the opening. This is another thing, that error in drug delivery. As such, we give very small amount. If the leak occurs, there is very inadequate volume of the drug available for a block. So always connect the syringe firmly and check that there is no leak. Now 99% of the time we blame the drug, but this is also myth. Sometimes very rarely we inject only wrong drug because of identification error. So always use different size syringe for a local infiltration and a spinal trunk, or a pre-filled syringe is an answer to this. Mixing the drug actually potentiates the effect, but rarely it is described as a cause because it might be changing the pH and unionized fraction of the drug is less available for a block. Inactive solution also can be a cause of a failure, but nowadays amide-linked drugs are very stable and they can be heat sterilized, so this cause is less likely. Most of us believe that drug is at fault, but there are few studies which refute the claim. I think bioavailability of the drug is low and causing the failure. According to AstraZeneca, they got a 562 complaints in 6 years for a failure, where they blame the drug for a failure. But the drug or the sample which they received was checked, and it was according to the product specification. Same way, LA Senner and Associates, they checked bupivacaine concentration when they were giving the repeat spinal. So before repeating the spinal, they took the samples and the LA concentration was checked, bupivacaine concentration was checked, which was found around 73 mics per ml. So this concentration, ideally speaking, should have given them effective block, but still the patient didn't have the block. So this suggests the maldistribution of the bupivacaine could be responsible in these cases. So now when the concentration was this high, concern about the neurotoxicity should be considered when we are repeating the spinal. LA resistance is very rare, but history of repeated failure with a dental procedure should warn us about this. And I think there is a speculation that NA channel mutation occurs in this patient, allowing the drug for not effective. But for this, very detailed investigation is required to resistance to be accepted as an explanation. History of scorpion bite is strongly associated with failed spinal. Again, the cause is, I think, altered sodium channels. Now, intrathecal spread is inadequate in some of the cases because of anatomical abnormalities of the patient with a kyphosis or a scoliosis, or ligament is acting as a septa and not allowing the drug for effect, spinal stenosis, intrathecal chemotherapy, and a previous surgery. Now, management depends on the nature of the inadequacy. If there is no block, either we have to repeat the spinal or give a general anesthesia. If there is an inadequate block, we can give a head down tilt and can wait for some time for the drug to move kifilad. Either flex the patient's hip and knees so the lumbar curve is straightened out and drug can move down. Even with catheter, they suggest that before repeating the drug, always manipulate the posture first and then only repeat. If there is a unilateral block and the surgery is on the same side, we can reassure the surgeon and the patient. But if it is on the another side, we have to again put the patient on the unblocked side down. If there is a patchy block and surgery is not started, we have to repeat or give general anesthesia. And inadequate duration, then anyway we have to go for general anesthesia. So the thing is, prevention is better than cure. So meticulous attention is to be paid to the technique. and the better understanding of the mechanism can help us in prevention. And slower onset of a motor or a sensory block is more likely to be inadequate. And most of the expected block develops in 15 minutes. So if there is no effect in 15 minutes, we have to try additional maneuvers such as change in the posture and all. Repeat spinal has issue in the form that all the adverse factors of the patient are still there. So it might fail again also. We may get erratic high level and consider the neurotoxicity as in the terms of neurotrauma to the partially paralyzed nerves and the high concentration neurotoxicity. Abraham and associate, they tried repeat spinal in few of the cases and it acted well. Their failure rate was 2.5% and recovery from the sensory and the motor blockade was same and there was no late complications actually. Option of GA is always there, but it is better to take that decision sooner, and GA is induced. We have to be careful about the hypotension because of the sympathetic block. Now the cases which we discussed, suppose the first case TURP, I would like to repeat the spinal definitely. Ortho patient, I might repeat the spinal and then or the rescue blocks and the supraglottic airway can be tried. Cesarean section, depending on the emergency, we have to go for a general anesthesia or a spinal. URS, ureterosrenoscopy, I would opt for general anesthesia. But always judge the risk-benefit ratio of the technique and then opt for the technique according to the patient. Future of the spinal is USG guided spinal, contrast mixed with the drug so we can visualize it, and pre-filled syringe. Though most of these are the theoretical possibilities, but such concern reinforces the view that every effort must be paid to ensure that the first injection is fully effective. Thank you.
Tarlov cyst. You have to use the Tarlov cyst.
I didn't put those Tarlov cyst plus the subarachnoid cyst, and they can give a failed spinal.
Yeah, we have one patient we have discussed, and I have asked for MRI, and what she told, she wants 12,000 rupees extra. She wants the cost of the MRI and everything. We have already prepared all articles as well as we have written the manuscript also to publish, but she is not allowing us for MRI. But see the case of Tarlov cyst, we are already discussed it. There is a 3 spinal I have given, all are failed. Motor power 5/5 in all cases.
And I think you had a late duration also.
But that was different. That was a late duration around 25 minutes.
Yeah. Another cases they suggest hypermobility syndrome also has having the failed spinal.
I think if you've been on the Facebook group for 2-3 years, I'm sure you have actually gone through all the scenarios, and everything has been discussed in very details. I mean, you can activate those threads again.
Actually, I have printouts only for that, and
that's
I prepared from that only.
I think that's why you covered everything. Thank you.
Practically, I've seen in my experiences that if you are using, like we are using routinely 27 gauge needle, and it is a needle to needle technique. Now the drug leaking from the hub and the injection joint is quite common, so we shifted to lure lock. But now, if you are shifting to lure lock, what is happening is in your anxiety to tighten the lure lock, the needle moves. So this is the thing that I think many of us might be facing, and this is a common issue. So yeah, I think.
I was just going to suggest that lure lock I'm finding very comfortable, especially after 25 and 26 number needles are being more frequently used. With lure lock, you are a little skeptical about the turning, but once you are in, there's no problem. I am very, very happy with lure lock. I was just going to talk about it actually. Yeah.